let us take up the next important topic, amyloidosis, on which a lot of questions come. Familial amyloidotic polyneuropathy is basically because of which amyloid? It is a transthyretin protein which undergo mutation, and that lead to a familial amyloidotic polyneuropathy. The main challenge in amyloidosis is classification, doctor. What is primary, what is secondary, what type of amyloid proteins will be found in different types of amyloidosis. If you know that, that is the end of the topic. A diabetic patient undergoing dialysis leading to amyloidosis. Which protein is involved? It is the beta 2 microglobulin, which is the amyloid protein involved in amyloidosis of dialysis, is what need to be remembered. Once more a similar question, hemodialysis is beta 2 microglobulin. Now in primary amyloidosis, which is the major type of the amyloid protein that you have, we have the light chains. AL type of amyloidosis is what you come across in primary amyloidosis. Now what is the classification of amyloidosis? Amyloidosis can be primary cutaneous, secondary cutaneous, primary systemic, secondary systemic, and heredofamilial amyloidosis. The broad division of amyloidosis. Now let us quickly look into it. AL is the amyloid light chain, and AA is a non-immunoglobulin protein. AL is immunoglobulin light chain, but AA is not immunoglobulin, and it is produced in the liver, and it is amyloid associated, it is called as AA. Then A beta is called beta amyloid otherwise. It is what you see in Alzheimer's disease. Then ATTR is the next type of amyloid, which is also called transthyretin. It is a part of familial amyloid polyneuropathies. It is the mutant transthyretin, which is the type of amyloid which is implicated. Then beta 2 microglobulin is a normal serum protein. It is a part of MHC class 1 molecules. It is typically found in long-term hemodialyzed individuals. Then you have amylin, which is found in pancreas of the patients of type 2 diabetes. Nowadays the new concept is why people get type 2 is, it is a amyloidosis in the pancreas leading to the development of the type 2 is a new story. Then in prion diseases we have PRP, which is a prion related protein which is also responsible for the amyloidosis. Then a very important thing is amyloidosis can also be classified as systemic and localized amyloidosis. Systemic is AL, AA and A beta 2M, and localized amyloidosis are because of A beta, IAPP, atrial natriuretic factor and calcitonin are responsible for localized amyloidosis. Then another classification which is in vogue is primary and systemic. Primary means in multiple myeloma and immunocyte dyscrasias, the amyloidosis is primary, and secondary is if there is any chronic inflammatory disease like rheumatoid arthritis or tuberculosis or osteomyelitis, it is all basically secondary reactive. Now one of the common questions asked in the exam is, which organ systems are involved in primary systemic amyloidosis, which organ systems in secondary systemic amyloidosis? You should be sure that in primary systemic amyloidosis, GIT, tongue is involved, heart and skin and mesenchymal tissues. Whereas in the case of secondary systemic amyloidosis, it is adrenal, liver, spleen and kidney are the predominant organs which are typically involved. This is a favorite question of examiner. Sometimes it is given as a question itself, that somebody had a macroglossia. Then what do you basically expect? Macroglossia is more to do with tongue and GIT, and it is more often a primary systemic amyloidosis. Whereas somebody had ulcerative colitis or Behçet's, where do you expect amyloid to deposit? Liver, spleen, etc. Because it is a secondary systemic amyloidosis is what you should be pretty sure about. How does renal amyloidosis basically present? It does not present with nephritic picture, hypertension, oliguria, they are not the nature. Rather it presents with proteinuria as a presenting feature. And primary basically has AL type, secondary has AA type. AA, where is it produced, doctor? It is a non-immunoglobulin produced in the liver. That's what we have already discussed. So the most common presenting symptom of amyloidosis will be weight loss, fatigue, cardiac failure, nephrotic syndrome, autonomic neuropathy, peripheral neuropathy, carpal tunnel syndrome, etc. Renal involvement can lead to nephrotic syndrome as a presenting feature is what need to be remembered. Once more, the next question of PGI June was amyloidosis, where do you find? We find in multiple myeloma, also in lymphoma, hypernephroma, not in thymoma. Certain malignancies can predispose to amyloidosis. Where do we find secondary amyloidosis? We find it in TB, rheumatoid arthritis, bronchiectasis, like a chronic inflammatory condition is the one which is responsible. Rheumatoid arthritis like conditions can responsible for secondary amyloidosis, and there the liver continues to produce the AA type of protein, which is a non-immunoglobulin, and that lead to development of amyloidosis because of a chronic inflammation. Now certain connective tissue disorders, not only rheumatoid arthritis, even seronegative arthropathies like ankylosing spondylitis, inflammatory bowel disease, they also can be responsible for the amyloidosis is what need to be remembered. This is a common match fixing astrologer's job you have to do, which immunoglobulin, which type of amyloid, and what type of amyloidosis. In multiple myeloma light chain, chronic inflammation like secondary amyloidosis, it is AA type. Cardiac amyloidosis, it is a mutant transthyretin ATTR, and in neural amyloidosis it is beta 2, so they are all the important types. This is how the cardiac amyloidosis, you can see the amyloid deposits in the interventricular septum classically in a patient with cardiac amyloidosis. So now once more quickly review, doctor, what are the various systemic amyloidosis that you know? Immunoglobulin light chains in plasma cell disorders, transthyretin in senile cardiac amyloidosis and familial amyloidosis, and AA type of amyloidosis in any chronic inflammation or familial Mediterranean fever or rheumatoid arthritis or chronic ulcerative colitis, etc. Beta 2 microglobulin in dialysis and immunoglobulin heavy chains in systemic amyloidosis, they are all basically systemic. Then you have some hereditary amyloidosis where apoprotein A1, A2, they are all basically involved in familial systemic. Then CNS amyloidosis include familial dementias, Alzheimer's disease, etc. In Alzheimer's disease, it is a beta protein precursor and prion protein in Creutzfeldt-Jakob, etc. And ocular amyloidosis is the newer entity, you should be sure. Which amyloid is involved in ocular amyloidosis? It is a lactoferrin, gelsolin, and keratoepithelin. They are the amyloid proteins which are typically involved. Then what are localized amyloidosis? Typically in medullary thyroid carcinoma, it is excessive calcitonin which lead to development of a localized amyloidosis is what need to be remembered. Another favorite question of examiner. In insulinoma and type 2 diabetes, which amyloidosis is involved? Amylin is the one which is involved. And in atrial amyloidosis, atrial natriuretic polypeptide, and in cutaneous amyloidosis, keratin is involved. Aortic amyloidosis, medin is a protein which is involved. So a lot of things are involved. Until your energy, brain can extend without any necrotic changes, you can remember. Because entrance is big lists at the end, you should not make life pathetic. And honestly, it is not that pathetic also. We read more but we represent less in exam hall. If it is burdening to the mind to remember, you must be very specific what to remember and dare to ignore others. That is most important thing in entrance. It's not that you read everything and remember everything. Now, amyloid is found in the form of excess calcitonin in case of medullary thyroid carcinoma, as all of you know very well. In multiple myeloma, what is amyloid? It is a AL type, as what we have already discussed. In primary amyloidosis, it is a AL light chain. Secondary, it is AA, and localized once more AL. Familial, it is transthyretin, which is AF, and senile, it is once more transthyretin. They are the different types of amyloidosis that you all know very well. There is a light brown perinuclear pigment seen in the cardiac muscle in an 83-year-old individual. Then what is it most likely to be? It is a classical description of the wear and tear pigment, which is called as a lipochrome or lipofuscin, which is a light yellow brown finely granular intracytoplasmic perinuclear pigment that we classically come across. And lipochrome is not injurious to cell. It is only a telltale story that this man lived for 83 years. So if you lived for 83 years, there are only two two privileges, lot of lipochrome in the body. Second is you have a chance to see obituary column of all your youngsters. So you have that only two privileges. It's a telltale story that this man lived very long. Now what is a lordaceous spleen in amyloidosis? Spleen can be involved in amyloidosis. Primary or secondary? Secondary, right? Now the involvement of spleen can be of two types. In the early phases of amyloidosis of the spleen, there is a deposition of it in the splenic follicles of the spleen that produce a tapioca-like granules, which is eatable. And splenic sinuses, their walls will be grossly engorged, and that is called as a sagospleen. But in the late stages of amyloidosis, it spares the follicles and connective tissue framework in red pulp, and that gives a lordaceous spleen. So lordaceous and sagospleen are the two manifestations of splenic involvement in amyloidosis. Early phase will be the sago is what has to be remembered. If there is a AL type of amyloidosis, what do you see in bone marrow? We find multiple myeloma, which is a plasma cytosis, as all of you know very well. How do you confirm the diagnosis of amyloidosis is the next important question. There are various ways to do that, and each method has its own sensitivity specificity. At least you must be very sure about what is the sensitivity specificity of each of these methods. You can do abdominal fat aspirate. You can do rectal biopsy, which are the commonly preferable methods. If it is a rectal biopsy, then it is 80% sensitivity, and abdominal fat aspirate has 70 to 80%. So generally preferable method would be a rectal biopsy would be a preferable sensitive specific method of identifying the amyloidosis is what you need to fundamentally remember. Now which type of amyloidosis is because the transthyretin protein is the next important question. Already we discussed that it is a polyneuropathy. Familial amyloidotic polyneuropathy is basically because of the transthyretin protein mutation. Familial Mediterranean fever lead to amyloidosis, and it is because of which important mutation? There is one important structure called pyrin. Pyrin is a 781 amino acids, and it is implicated in familial Mediterranean fever, which presents with fever, with synovial pleural peritoneal inflammation, and that is also associated with amyloidosis. So pyrin mutation is the underlying cause. Now lot of questions are asked about stains which we use for detecting the amyloid protein. Another important area of amyloidosis you should be sure. We use the Congo red, as all of you know very well, that Congo red typically become positive if there is amyloid, and this is how the amyloid deposition in the glomerular stain with the Congo red typically looks like. But don't tell that I am seeing a birefringence. Where do you see that? We will take up in the next question. Apple green birefringence. Now once more the question is, how do you stain amyloid? It's Congo red. If you do Congo red with normal light, it will show like our earlier slide. It will impart pink or red color to the tissue deposit. But if you put a polarized light, then it will show the green birefringence is what you need to remember. This is how you can say, are you able to see green birefringence, doctor? This is under polarized light. Earlier how was it looking like? This is without polarized light, under the normal light it typically will be staining pink or red is what you have to be very sure about. And if you do electron microscopy, you can see the various amyloid fibrils. Classically the amyloid fibrils is what you are able to see at various locations. Now once more a repeated question, what stain we use for amyloid? It is Congo red. Then we also use thioflavin and Congo red together. Then what is this thioflavin? Thioflavin T, it will bind with amyloid fibrils, not with the monomers, and that gives a typical spectral shift. So other than Congo red, we also use the thioflavin. Once more, May 2006 exam. Examiner's favorite question is amyloid deposits are identified by Congo red, thioflavin. One more thing, crystal violet also we use to identify the amyloid. Now anyway, let us summarize. different stains. How does amyloid basically look like is a favorite issue of examiner. Galls iodine we can use, it will impart purple color to amyloid. Hematoxylin eosin He staining, it will appear like an extracellular homogeneous structure, cyanophilic hyaline material. That is a description of amyloid. If you use methyl violet and crystal violet, it will be rose pink in color. If you use the Congo red, ordinary light it looks pink, and if you use polarized light it will be apple green, and if you use thioflavin it will appear yellow like our earlier one, yellow or ultraviolet, yellow under ultraviolet light. Then we can also use various immunohistochemistry stains, etc., to stain the amyloid. If you do electron microscopically, how does amyloid basically look like? We have discussed that on electron microscopy, it's of indefinite length and a diameter of about 7.5 to 10 nanometers is the typical appearance of amyloid, which we have seen earlier slide, how on electron microscopy it looks like. Yeah, you can see here, you can see under the electron microscopy the amyloid deposits can be seen as a infiltrate within the normal heart tissue, and it is seen as this kind of fibrils which are about 7.5 to 10 nanometers in diameter is what need to be remembered. If you want to look at beta pleated sheet like structure of amyloid, what is the best way? It is the X-ray crystallography is what we basically use, and under that it looks like a beta pleated fibrillary congophilic substance is the description of the amyloid, as all of you know very well. So that completes the stains used, classification of amyloidosis, different types of amyloid and where do you find them. They are the 3 to 4 major issues. Next time you open, how many pages will be amyloidosis in Robbins pathology or any pathology? 8 to 10 pages and 1 hour of preparation generally, right? But now you should say I can revise in not more than 5-6 minutes before one coffee is exhausted.